Compulsive disorder, resistant OCD. Thank you, Mr. Chairman. I would like to thank the organizers of this meeting as well, because this has elevated the quality of Turkish psychiatry to a great extent, especially what we'll listen to in the morning and what we're going to be listening to later on. I'm starting my speech. OCD is included in anxiety disorders in recent years because some people want to see OCD as a separate entity, separate disease group. This is led by the leading OCD specialists in the world. Therefore, we're going to be talking about these together. Maybe 1, 2, or 3 more years, but later on we're going to have to hold totally different panels on OCDs. In 2012, we're going to be having DSM-5. Unless there's an extraordinary change, OCD will no longer be included in anxiety disorders group, but it currently is. In OCD, as is the case in other diseases, this is one of anxiety disorders. Everybody here knows what OCD is, I think. Undesirable thoughts, images, symbols, emotions, and behaviors that are totally undesirable. A very important disease. It lowers quality of life. All studies indicate that it disrupts quality of life at least as much as schizophrenia. The worst thing about the patient is that at least in schizophrenia the individual is not aware of what's going on, but in OCD the individual is acutely aware of everything that is happening. In family and social relations, it really take a heavy toll. Academic development and work life is impacted negatively, especially if it starts when people are still students. Then they can rarely complete their education. Studies show that there's at least 2 years of loss of business life in people. This is the least. If you'll notice, it's a lot higher on the average. In our country, this is not known very much, I think, but 13% of all cases, they attempt suicide because of their OCD signs, because they experience heavy depression, they may go into psychosis, they may have comorbidities with other anxiety disorders. Suicide rates are a lot higher. These are only those who attempt suicide because of OCD signs. According to WHO, it's one of the 4 most important mental diseases, OCD, and all diseases in the world, not only psychiatric, among all diseases in the world. It's ranked as the 10th disease that causes competence loss. Unfortunately, these are all very negative things. Apart from all of these negative things, the important thing for the doctor is that the prognosis is not so good. 2 to 3% in the community, in society, this 2 to 3% rate does not really have much impact on people. 70 million Turkey's population, it means 1.5 to 2 million people who are experiencing OCDs. Some of these people don't even come for treatment, as you know. Some try to get treatment so they have better chances. All studies show that 40 to 60% of such people either heal partially, or they do not respond to treatment at all. This, of course, is another very high ratio. It's so difficult to get a response to treatment that in the YBOCS scale, if we can have 25% rate, this is accepted as response to treatment. In many studies, these mean a healing of 23 to 43%. Of course, for the treatment of this disease, there are anti-obsessional medications. These are serotonin reuptake inhibitors. Most of the time, this is what we use. Resistance to treatment, of course, in this disease, maybe we're one step ahead here. At least we have a consensus on resistance to use at least 3 anti-obsessional diseases for sufficient period of time and sufficient dose, including clomipramine. Then we may call it resistance to drugs. And if we cannot use, of course, we have to explain, is it because of the side effects? And is this very important, you may ask? Yes, currently in Turkey, some treatments are not being applied. It's important, for instance, that when you consider psychosurgery on a patient one day, we have to prove over the medical records of the patient that we have tried this. If this is missing, you cannot take the patient to surgery because you must have had him at least on 3 anti-obsessional drugs beforehand. So these sound very theoretical right now. What is sufficient period? 12 weeks. That's also a consensus for at least 3 months. And you should have the patient on the medication for at least 3 months. Of course, it's very hard to convince patients to do this, but if you can succeed in doing so, really, during those patients who do not change over long weeks, you have to insist. You may start observing them getting better, because 1 month, 1.5 months, 2 months, if a patient can believe that they're going to benefit from the medication, they will continue. Sufficient dose should be the highest acceptable dose of the medication, provided that there is no barrier to using the highest dosage. Now here, I'd like to draw your attention to something: obsessive-compulsive disorder. Basic treatment dosages are twice the dose of antidepressant treatment, 75, 20, 100. This is how it goes in antidepressant treatment. Therefore, we have to have the patients on high dosages. If you can get results from lower doses, you may be facing one of 2 things. You may have a very good respondent before you, but please don't miss that patient. Elevate the dosage and try to finish it off, because they may not have a chance for the next treatment. And the other one may be that you may have misdiagnosed, and this may be just a depression with obsessive characteristics. So, but it's really, then you will never call it OCD then. It is a depression with obsessive kind of features. About this medication, I think the dosages are not yet established. For instance, case study says 50 milligrams yield very good results. Don't try to give it to anyone based on the laws of today, because expert witnesses will get you, because we're not authorized to prescribe those dosages. Plus, these are not reimbursed. Top dosages, these are the legally approved dosages. Apart from this medication, though, for this medication, for depression, 50 milligrams is the top dosage. If you're using 60 milligrams, you must have an OCD patient, otherwise you shouldn't be using 60 milligrams per day. Under these circumstances, once we accept a person to be resistant to treatment, of course there are things we can do. One of the things that need to be done is to bring into play cognitive behavioral therapy. in many places in the world, cognitive behavioral treatment has to come into play at first stage. However, we have to be realistic. Nowhere in the world, apart from very special places, no one brings this into play at the first stage because there are not too many cognitive behavioral specialists, particularly very few in our country. But it's very beneficial at the second stage of the disease because in all studies that have been conducted, if you do both of them simultaneously, the medication and cognitive behavioral therapy, you get a better outcome. This has been investigated with imaging techniques as well. It's interesting. The areas that are impacted by the brain and the areas of the brain that are impacted by therapy and by medication can be shown separately. It's so interesting for me, and I'm going to delve into this later on. Pharmaceutical companies are very seriously trying to come up with medications which impact the part of the brain that gets impacted by therapy. For instance, how can you have therapy with medication, you may ask? Well, yes, of course. Think of Viagra. There were lots of treatments performed for erection beforehand. Now there's Viagra, so no one needs to talk about it anymore. They just take the medication. So if they can come up with something similar, we'll be talking about things that are totally different. However, right now there is no sign of it. I think by the time I learn how to use this pointer, the speech will have ended. Reinforcement therapy. Reinforcement therapy are small dosages from other medication groups. These are added to treatment, so this kind of reinforces the therapeutic drug. Some of our assistants do this. So much from this medication and another medication, but this is not reinforcement. If you are doing this, you're treating OCD plus schizophrenia. For this, atypical antipsychotics may be used. There are a variety of things that can be used. I'll go into them. Risperidone, olanzapine, and ketiapine addition may reinforce the treatment, some research shows. Previously, there was neurosis clinic in Bakırköy, which was working very busily. We used all of these one by one, and they really increased the effects of the medication. But please, not on the first minute of the first day. Adding risperidone or olanzapine to any antidepressant is not the right thing to do, provided that the patient is not also in psychosis. Because the most important problem all over the world is these medications will be used throughout life, and all these medications that we keep adding, if they're used lifelong, we don't know what kind of risks will be emerging later on in life. Maybe we do very well by adding risperidone, but patients will be taking this for long periods of time. We don't know what will happen to them in the future. And as you know, these medications have very serious side effects. Maybe one day we may come together and talk about anxiety disorders and comorbidities, but it will not be fruitful, to be honest, because these types of diseases, when they are comorbid with other diseases, no one knows what to do about this. Almost, let's say. For instance, the most renowned, the leading psychiatrists, you may ask the following question in International Congress. Schizophrenia and OCD, they are concomitant. What are we going to do? Shall we give OCD medications at these dosages or schizophrenia drugs at other dosages? The answer will be empirical. They say whichever one is more predominant, try to treat that. And in our clinics, we do something more empirical. Whichever is predominant, we ignore the other and then treat the predominant one. So we treat schizophrenia and OCD is neglected. Same thing goes for bipolar disorders. 90% of the time there's anxiety disorder comorbidity, but say it's too exaggerated. It's only 50% OCD plus bipolarity. What to do? Well, no one really knows. The smarter ones say we may use benzodiazepine, but benzodiazepine using that does not benefit bipolar disorders. If you use the other ones, you then increase the other disease. So in the end, there's no consensus. And no consensus for other comorbid diseases either. And if the dosage is beneficial, the patient gets benefit. If not, things remain as they are. Another thing, in our country this is done very frequently, clomipramine with lower dosages and adding SRI medications. However, when doing these things, 2 SRIs may be added to one another, things like that. You have to be very informed, very careful. And the competencies of our hospitals are very limited. I guess there's no hospital in Turkey which may investigate a medication value in the bloodstream. For instance, together with clomipramine, if you give them together, very low dosage, 10 milligram, clomipramine may increase 400-fold in a person's blood. So you have to be monitoring blood as well. But sertraline or clomipramine, they do not elevate as much when given together. Then you may have a more innocent picture, but it's an indication of how developed our country is, asking for making the physician accountable. Let's say there's too much clomipramine in blood. The forensic department, let's say, has proven this, so it may not be so easy to get away in a lawsuit. Yes, as you know, complaint ratios have risen. Once a week I go to the Patients' Rights Commission to defend my own people. Most of the time we end up fighting. And from time to time there have been some malpractice suits initiated. Some people have even been sentenced. So we have to be very careful about what we do about these things from now on. Clonazepam is a very important medication for this disease. Anti-obsessional, that's what it is. If in an OCD treatment we're talking about benzodiazepine, this means it has to be clonazepam. The others, of course, they may bring down anxiety. I don't object, but treating OCD directly, that's your purpose. The others have no place in the treatment of OCD. However, in spite of this, there are some reports which say it is no different than placebo. There are some who say it's as effective as clomipramine. We have used it in our clinic from time to time for some patients. Well, everything is for some patients anyway, and not for the others. And it really increases efficacy, improves it. Also, if there's excessive anxiety, suppressing this ensuring compliance for behavioral therapy. So it may be used for these purposes, but you may use other benzodiazepines for this particular case as well. We're not doing anything directly for the disease there. Adding buspirone, well, that's a very controversial medication in psychiatry. Some trials show it's very effective. We use it a lot, and I don't think that we have yielded any significant results. However, there was a defect here, and you can't find buspirone anymore, I guess, right? No. It had one defect. It was 5 milligram, and the added dose here is 60 milligrams. you give them a palm full of Aleppo pill, and then you say there's more medication, and you have to take 4 morning, noon, and evening. So, as you know, we have a negative image in society. Anyway, you may scare the patient. However, there are 20 milligram tablets outside of Turkey, so you can prescribe them 3 times 1 and finish it off. But that also has an effect, convincing the patient to have 2 of this and 4 of the other. That was really a bit excessive. Lithium and temperament stabilizers, they don't have a direct benefit, but there are bipolar patients, and we give them very high dosage medications, so don't forget that. They cause mania, so we may have to use these medications even in the absence of mania. There are some cases of familial mania, so in those cases we have to start using those medications, or if there are some traces of undiagnosed attacks, then the other one is when treating a very severe OCD case, the patient may call you one day and say, I feel very good, thank God, I have no signs, I never thought that I could feel this well. If you hear this, please ask them to come right over. I say to my assistants, you cannot really, it's hard to get along with psychiatrists. We don't like them if they get well, we don't like them if they do not get well. Sometimes during treatment, OCD signs may be eliminated totally. It's like you have nothing to do, because it's one of the worst signs of OCD, and mania. Everything you have to give for OCD is a contraindication for mania, so that's a very undesirable place to be in. It is seen very seldom, but it is seen, so please be careful when suddenly your patient feels very good. Other reinforcement trials with other medications, they have conflicting results, but they may be worth trying sometimes. Oral morphine we never used. Stimulants, we have not used them very much. Tryptophan, it was a big hope, but then it was a big disappointment. You can't find it anymore. Pindolol it emerged in the mid-90s. In these kinds of diseases where medications would have an impact, and in depression we thought it was going to yield very good results. We used it quite a lot, but we never really yielded any significant results. Of course, these are clinical observations. Oxytocin we never used. Androgen antagonists, a Spanish team found this by coincidence totally. We used it in our own clinic, and really many different things can happen, but ethically we could only use it on women. One defect is that I don't know what the current situation in Turkey is. This was 5-6 years ago. It had injectable forms only. It didn't come in pill format, so that caused a problem. We would calculate and try to inject it like that, and of course we cannot give it now because it's not reimbursed. It's only reimbursed in cancer cases. In other places in the world, it did not draw much attention, so it was like a good memory now. Venlafaxine trials, some of them have yielded good results. When you encounter an unrespondent, if it's the last resort, if it's worth trying, as you know, you have to use high dosages of depression treatment. We don't have this in our country, so it's not our concern, but trials using phenelzine have, some people say it's as effective as clomipramine. A trial has been performed to compare it with fluoxetine. only apart from symmetry obsessions, it has shown no superiority. These are old medications. People are not interested. For instance, after this result, you would expect a couple of people to try this, but there's only one trial performed by someone. It's not followed up by anyone else. As you know, we don't have medications anyway, so it's not that important for us. IV treatments. There was clomipramine, and we used to bring it from abroad about citalopram. We never used it, but there's citalopram in other countries in IV form. In both of them, these have to be administered under hospital conditions. You have to be very careful. There are side effects you have to watch out for. First effect is observed immediately. We have observed clomipramine personally. However, this fast effect, as you know, it passes through the liver. That's the reason. So it goes to the brain very fast, and later on you may continue with other medications. It was a hope in spite of everything for the patients, but however, because the medication is not available, it's not very meaningful for our country. Then we have the somatic treatments. In the morning session, the second speaker talked about this. This is very serious stuff, it seems. I don't know how it's done today. They only conduct research, electrode placement in the brain, stimulating, and then trying to cure depression. This is now also being tried for OCD. There are dramatic results. There are videos of it. I had seen actually. Suddenly, after 1 hour of stimulation, depression is completely eliminated. They're all experimental studies. I hope maybe 10 years, 20 years later, they may become more practical applications. Sorry? We're not as fast as you are. 2 days ago, FDA has approved for OCD. This sort of says it may be true because this is a very, very bad disease. Of course, my concern here is that especially those who live in Istanbul, they know Istanbul medical market. In private hospitals, of course, people do not perform seriously. A very bright neurosurgeon may place one in the brains of those housewives claim to be cleaning their hands too frequently. Thank God they cannot dare, it seems to me, because in Western countries it's a very serious thing. Not everyone would be subjected to brain stimulus. A group treats this under the circumstances I've just mentioned. The files are turned over to another group. For instance, we are treated in Bakırköy, let's say. We turn the patient and the files over to Chapa. They check it. They say, okay, what you've done is right. She may go for surgery. Or they say this part is missing. They either complete it themselves or the other group does. And later on they come together and they arrive at a decision. They take it very seriously, but of course it seems to me like it will not be taken as seriously in our country. Okay, I'll be wrapping it up. Last slide anyway. Vagal nerve stimulus is a very suitable treatment method for depression. However, we don't have sufficient information for this disease. We had discussed this very often. Nevzat Bey is not here, so we can talk about this very easily. At the outset, it decreases. However, in the long term, there's no difference in results. However, it's still a hope at the start. It's not like it cannot be done. Psychosurgery, 35 to 65% of success can be obtained. There are very serious clinics in America on this. They have 1 or 2 a month. As far as I know, if I'm not wrong, that is, please correct me if I am. In Istanbul University Medical School, a couple of cases have been performed. I mean, at Chapa, and I think at Gazi University as well. There's one in Ankara too. So I know they have been performed in a couple of places, and I guess they have been performed in under very serious and scientific conditions, hopefully. ECT does not have a direct effect on OCD. Of course, let's not ignore depression. We can have an OCD person may have ECT performed, but it must be because of the depression. I would like